The college network, something wrong with the college network, I suppose. I'll request if you are having any audio issues to put it in the chat box. So I will stop and resume after that. Okay. I'm keeping a watch on the chat. Okay. So I was. Did you all hear about mucormycosis? What I was speaking about it? Yeah. So when we manage a patient of invasive fungal sinusitis, one of which is called mucormycosis, what we do is already there is a necrosis of all the nasal and paranasal sinus tissues. Necrosis means it's already dead tissue. So when you have dead tissue in the nose and sinuses, it has to be removed. And when we remove all this dead tissue, there is going to be a huge cavity which is formed. And that is one of the causes for development of secondary atrophic rhinitis. So I suspect all of you will be seeing few cases of secondary atrophic rhinitis in the OPD. And therefore, this topic is going to be an upcoming important topic for the examination. All right. Any doubts so far with the history taking, symptomatology?
No, sir.
Okay. So anything else, Vaishnavi, in your case sheet?
Yes, I have written the treatment history and family history and personal history.
Anything was significant in that? Nothing, right? All are negative.
Yes. Yeah, yeah.
Okay. So you can stop presenting.
Okay, sir.
So someone else also wanted to present. They said they have a PPT. Who is that?
Sir, it's Nishanti.
Nishanti, is it? Okay.
Yes, sir.
I will give Nishanti presentation, right? Just give me a second. Okay, Nishanti, I've given you presentation rights. You can present your PPT.
Yes, sir.
I can see your desktop, Nishanti.
Yes, sir. Is it visible, sir?
Yeah, it's visible.
Shall I start, sir?
Yes, please start.
Um, this is Miss Shalini, 31 years old, female, Tailor by occupation, residing in RR Nagar, Bangalore. She belongs to upper middle class, and date of admission is 29th May 2021 and date of examination is 29th May 2021. Chief complaints are patient complaints of nasal obstruction bilaterally since 5 months, patient complaints of nasal discharge since 4 months, patient complaints of loss of smell since 4 months, patient complaints of foul smell perceived by others since 3 months, and patient also complains of headache since 1 month. History of presenting illness. Patient was apparently normal 5 months ago. Patient developed bilateral nasal obstruction, which was insidious in onset, gradual in progression, and present all the time. Aggravated at the time of nasal discharge and relieved on medication. She used nasal decongestants. There was no diurnal variations or postural variation. Patient complains of bilateral nasal discharge since 4 months, which was sudden in onset, gradually progressive, and intermittent in nature. Nasal discharge of greenish yellow crust, which bleeds on removal, were reported. Patient also complains of associated loss of smell since 4 months, sudden onset, and gradually progressive. Patient also complains of foul smell perceived by others but not her since 3 months. There was no loss of taste sensation. Patient also complains of mild headache on and off on the frontal side, insidious in onset and gradually progressive. It was aggravated on exertion and relieved on rest and medications, which was paracetamol taken by the patient. There was no postural or diurnal variation.
Okay, so in the history of presenting illness, one thing I would like to say, you cannot have relief with nasal decongestants. So characteristically, nasal decongestants do not give any relief in atrophic rhinitis. How do nasal decongestants work? Basically, they reduce the edema by causing vasoconstriction. They reduce the edema of the turbinates. So when there is a edematous condition, inflammatory condition or other condition causing edema of the turbinates, such as allergy, infection, then when you put topical nasal decongestants such as oxymetazoline or xylometazoline, there is a decongestion effect, and that leads to improvement in the obstruction. In atrophic rhinitis, like I mentioned earlier, the pathophysiology is different. So nasal decongestants typically do not give any relief to the patient. Okay. So
Yes.
also when you are writing the treatment for atrophic rhinitis, nasal decongestants are contraindicated because already there is atrophy and damage to the tissue. And if you give nasal decongestants, then it will cause further obstruction to the blood flow, and it causes worsening of the atrophic rhinitis. So it is one of the contraindicated medications in atrophic rhinitis.
Yes, sir. Antihistaminics and nasal decongestants are contraindicated. I forgot about it. I'll
Yes,
correct it.
even topical steroids are contraindicated. Patients do use it on their own, but they don't give any relief when they use.
Yes, sir.
Okay. Go to the next slide.
But in case the patient has used a topical steroid, though it is contraindicated, in presenting illness, we'll write it or we shouldn't. How is it?
If the patient has used it, you should write that the patient has used it, but there is no relief. Or whether when they used it, any bleeding was there. Sometimes when there is atrophic rhinitis like this, they keep using nasal steroids, it can cause bloodstained discharge to occur. All these things you can write in the history of presenting illness.
Okay, sir. Thank you. So negative history, no history of trauma or and surgery, no history of bloodstained discharge, no history of rhinorrhea, no history of facial swelling or pain, no history of ear pain, no history of itchy, congested or watering eye, no history of snoring or mouth breathing, and no history of sneezing.
See, a little bit you have to be careful when you're writing. See, rhinorrhea is nasal discharge. Previous slide you have written about nasal discharge, correct?
So, but that was crust.
Yes, so but you mentioned it as nasal discharge, no? So better not to write it again. Why to cause confusions? Secondly, blood-stained discharge can be there after crust is removed. Okay.
Okay, so I'll avoid these 2 points.
Yeah.
Past history, no history of similar complaints in the past, no history of previous surgeries, Patient is not a known case of hypertension, diabetes, asthma, TB, syphilis, leprosy, and there's no history of drug allergy.
Okay, continue.
Family history, not significant. Personal history, diet, adequate, mixed diet, appetite is maintained, sleep disturbed due to nasal obstruction, bowel and bladder movements are normal, addictive habits like smoking, alcohol, or sniffing is absent.
Sniffing what? So just don't mention specifically unless there is some reason. So here you might be wondering whether sniffing tobacco or sniffing such as products such as cocaine, they can cause secondary atrophic rhinitis. So you can specifically mention no history of sniffing tobacco or other drugs. If you are thinking it will contribute to the case, you should mention specifically. Okay.
Yes, sir. Summary. Here is a patient of 31 years old who complains of bilateral nasal obstruction, nasal discharge of greenish yellow crust, loss of smell, and mild headache.
Okay, so see here again you have mentioned as discharge, so that's why I said don't put it as rhinorrhea. No rhinorrhea.
Yes.
Okay, so now when you are presenting in the exam, I would suggest don't stop like this and give a summary after history unless they ask you. If the examiner asks you, you have to do it. On your own, you should not do it. Now, if you stop, then the examiner will take the opportunity to go into more details about history, differential diagnosis, and how to improve the history. Unless you are confident and you don't want to proceed with the other aspects of the case on your own, you don't take the initiative to stop like this. Okay.
Okay, sir.
It's a good habit for yourself to understand how the history can be improved when you are doing it, but not in the exam.
Yes.
Okay, so I don't generally we don't as ENT people teach physical examination, general physical examination, and systemic examination. Only thing is, if there is something which is likely to be significant or contributing, then we can discuss it in more detail. So one of the reasons for atrophic rhinitis can be hypothyroidism. So that can affect the multiple systems. So in such case, then possibly we will have to discuss. Otherwise, I will not stop you here. You are going to learn these things in other classes, general medicine, general surgery, pediatrics. So we are not going to go into this. Go to ENT examination.
Yes, sir. Sir, I have a doubt.
Yeah.
In systemic examination, when we are doing CNS, we are telling there is no neurological defect or higher mental functions are normal, but we should also comment on the cranial nerves function, no, sir. But
Yes.
here there is loss of smell, olfactory nerve isn't functioning properly. So it's significant, right?
See, if there are multiple other cranial nerves involved, suppose you are suspecting some medullary problem or some cerebral problem, then you can go into detail about the systemic examination. See, for example, if I have a case of spreading skull base osteomyelitis, or there is a tumor in the olfactory cleft, which is pressing on the other cranial nerves and causing a problem, then I will separately mention in the cranial nerve examination. Otherwise, it is a part of smell examination is a part of routine ENT examination. It's more appropriate to present it.
Okay, sir. Yeah. So local examination of nose, external examination. No external abnormality is seen in the nose, such as deviation. No scars, sinuses, cysts, ulcers, or growth on the nose. Normal skin over the nose. There is no decoloration. And tip tracing test, ala, columella, vestibule, septum are normal. So by anterior rhinoscopy, the nasal septum appears normal. Greenish yellow crust covers mucosa of septum in the right and the left nostril. Nasal mucosa, dry and pale mucosa is present bilaterally. Nasal floor, dry mucosa over the floor bilaterally. Lateral wall, greenish yellow crust are formed over the mucosa, and the turbinates are atrophied and reduced to ridges bilaterally. Nasal cavity is roomy, and the nasal mucosa, the color, it is pale. Bleeding is here also I'll avoid bleeding, sir. Maggots are absent.
I would suggest you don't put negative history like this, especially like for in this case you have put maggots are absent. So when you present it, if maggots are present, then you say maggots are present in the nasal cavity. So why do you want to put a separate heading which is not part of the routine case sheet saying maggots are absent and bleeding are absent? So if you do so, then they will ask you, are you expecting in this case? Then you will go into details about myiasis. What is the genus of the fly which causes myiasis commonly? And what is the life cycle of the fly? How do you identify that they are maggots? And where else the maggots can affect? Is it only nose? So these sort of questions, if you want to answer, you want to lead the examiner, you can put it up. Otherwise, just leave it. Don't stress on things which you are not seeing. Okay.
Yes, sir. I'll avoid these two.
Yeah.
Sir,
And
and
spelling
I have
rhinoscopy is wrong. It's not rhiniscopy, it's rhinoscopy.
spelling mistakes, sir.
Yeah.
Sir, I have doubt. In this case, even in meatus, will the crust be seen?
Meatus, it will be everywhere. In fact, the middle turbinate will be very thin and small. So even on the lateral wall in the meatus also you will have crust.
So here I can mention about the meatus that the crust is present.
You can just say that the nasal mucosa lateral wall is covered by a thick greenish crust. So you cannot, when that so much crusting is there, initially you cannot see whether it's in the meatus or no. When you are decrusting with the help of a forceps, that time you can make out that it is partly in the meatus. So why do you want to mention it? So you are not going to do any decrusting, right? You can say that there is a very large greenish crust which is covering the entire lateral wall.
Yes, sir. Functional test. Sir, actually, posterior rhinoscopy, my scanner wasn't working, so I couldn't upload. Shall I just put the pic of the diagrams in the chat box now?
Yeah, you can put it. Or what you can do is you can share it at the end of presentation, or you can stop presenting your slide and then share the picture separately.
Okay, sir. So functional test, olfactory function test. Patient is unable to perceive common odors like coffee beans, camphor bilaterally. Cold spatula test, marked reduction in fogging on both the sides. On the tongue depressor. Cotton wool test, there was no movement of the wisp of cotton bilaterally. Cotton test was negative.
What is camphor?
Camphor,
Yeah.
the white, you get it in the, you use it in the household, the camphor ball.
Yeah. But I see basically why I'm asking you, there are two reasons. One is the main reason is when you use any substance which triggers off the trigeminal nerve sensation. Okay, it can be like your alcohol or any petroleum product. It irritates the trigeminal nerve. So it sometimes gives a false positive. That is, there is a. It says the patient will feel that there is some smell being perceived. So such substances such as ether, alcohol, and any petroleum products are to be avoided in olfactory function test. I'm not saying in this particular case. Generally, in olfactory function test, it is to be avoided. Now, when you come to camphor originally it is a resin of a tree. Okay, it is what is an extract of the resin of one of the tree. But nowadays, what we get it, most of it is mostly composed of petroleum derivatives. Because the tree camphor, that resin is very expensive. It is available, it is very expensive. Most of what we get is actually a petroleum product. So I would suggest not to mention camphor. You can say other things like jasmine flower, like odor, perfume of jasmine flowers or rose petals. So these are also commonly perceived and understood smells. Basically, you should choose a odorant which the most of the people can easily identify, which doesn't stimulate the trigeminal and which is easy to carry around. So these are the reasons why particular odorants are selected.
Yes, sir, done.
Yeah.
I'll correct.
Yeah. No. So it's not a personal feedback. It is, see, my job here is to help you all to improve. So it is That's why I'm telling you. So none of you should take any of my feedback personally. Okay?
Yes, sir.
Okay.
Examination of paranasal sinuses. Signs of inflammation like redness, edema are absent bilaterally. And on palpation, maxillary sinus tenderness is absent bilaterally. Frontal sinus tenderness is absent bilaterally. Ethmoidal sinus tenderness is also absent bilaterally.
Why did you mention redness and edema?
So when there is allergic conditions, you'll have redness and edema. Right?
Where is it visible? Sinus edema? It's not visible, no? It is inside the sinus. It will not be visible to you. So you should not mention separately. That's why in the UG level, we only talk about the tenderness. So don't mention additional points like redness and edema. Okay.
Okay, sir. So examination of ear, examination of oral cavity, examination of oropharynx and were done. All were found to be normal. Examination of neck on inspection, normal color of the skin, no swelling or scars. And on palpation, there was no palpable lymph nodes.
Okay. You want to stop and put up your posterior endoscopy picture?
Okay, sir. Actually, my computer audio has some fault, so I'm using my mobile. So in my mobile only, I'll upload the picture.
Okay, then put it in the chat. No problem. I will put it up on the screen.
Yes, sir. Sir, have you seen it?
Yeah, it's loading. Just give me a minute. I can see the anterior endoscopy diagram.
Yes, sir. Next picture is about posterior rhinoscopy.
Put that also up.
I've actually loaded it, sir. Maybe it's loading for you.
Okay. Yeah, I got it. Just give me a second.
Should I explain about it, sir?
Just give me a second.
Yes, sir.
My connection seems to be a little slow. Yes, can you see your picture?
Yes, sir.
Okay. So this is what Nishanti has shared. Anyone has any feedbacks?
In this picture, you can see greenish yellow crust present on the lateral wall as well as on the nasal septum. And the turbinates are atrophied and reduced to ridges.
Okay.
There is dry and, there is roomy nasal cavity.
Okay, so for atrophic rhinitis, it's appropriate that you have drawn small turbinates and there is greenish material inside. I don't see anything difficult in drawing this, but good that you do it. All of you have, when you're writing a case sheet, I want you all to draw. For this particular case, not much challenge. Only thing is when you're drawing the anterior endoscopy findings, turbinate should be very small. Okay, I'll just load the posterior endoscopy. Just give me a second. Okay, you should be seeing. Do you see the picture?
Yes, it's
Okay.
In this picture, you can see the turbinates are atrophied with greenish yellow crust over it, and the bilateral eustachian tube opening is normal.
Okay. So again, a good attempt. This particular disease, atrophic rhinitis, not much of a challenge in drawing the findings. Basically, the turbinate should be small and the crust should be shown in the cavity. That's all. Okay.
Sir,
So what is
I
your
have a question.
diagnosis?
So because of the nasal discharge, if the eustachian tube gets blocked, how do you draw that, the blocked one?
Just draw that crust covering the eustachian tube opening in the posterior endoscopy. That's all.
Okay, sir.
Eustachian tube cushions also will be affected. So atrophic rhinitis can involve the pharynx and larynx, and it can cause pharyngitis sicca initially, and then later on leading to atrophic pharyngitis and laryngitis, which are little rarer conditions that can also occur in severe atrophic rhinitis cases. So Nishanti, what is your diagnosis?
Yes, sir. So different, sir. I think I can't switch it to my screen.
No, you still have the presentation rights. If you want to present, you can share
Is
that.
it? Is the screen seen, sir?
No. You are not seeing your screen.
Sir, I'm uploading it again. 1 minute.
Okay. I'm downloading the attendance in a minute. Okay, I've downloaded the attendance. We are reaching the fag end of the class, only around 15 minutes left. Those who want to leave now can leave. Okay, but I think most of you seem to be interested. Let us wait for Nishanti to finish her presentation. Otherwise, we'll have a little bit more discussion and then we'll end the session.
It's seen, sir.
One second. Yeah, we can see your slides.
Yes, sir. Differential diagnosis of the above case: bacterial rhinitis, sinusitis. It can be any allergic rhinitis also. Tuberculosis, syphilis, leprosy, atrophic stage of rhinoscleroma, and foreign body or rhino.
So I will dispute your methodology you used to select the differential diagnosis. See, you are taking the differential diagnosis from your history alone, but at this point of time, your differential diagnosis should be from the examination and history. So if you look at it from that point of view, you can rule out bacterial rhinitis, sinusitis, right? Because and even foreign body. The reason why I'm telling is because both sides you have seen atrophic turbinates and characteristic crusting, loss of smell. So the only differential diagnosis is atrophic rhinitis. The only differential part will come in whether it is primary or secondary. So if you look at the secondary atrophic rhinitis, you can consider the granulomatous diseases such as TB, leprosy, etc. You can also consider the atrophic stage of rhinoscleroma. Possibly, since there is no history of surgery and other things, I will not consider iatrogenic atrophic rhinitis. All right. So basically, it will be either a secondary atrophic rhinitis caused by an infectious or granulomatous condition, or it's a primary atrophic rhinitis. Okay.
Sir, granulomatous condition also, since in past history we have already mentioned that the patient doesn't have such complaints, so that also will be ruled out, no, sir?
Sometimes there will not be any complaints. Tuberculosis is a prime example. It is, what do you say? I think you have heard your other professors tell you it is a masquerader. It's a master masquerader. It can masquerade any other disease. So sometimes it is not having very significant clinical presentation, and fever may also not be seen. I gave you the example of my case. He had no history of fever. Okay.
Yes, sir.
So it can still be considered at this point.
Okay, sir. So provisional diagnosis is primary atrophic rhinitis.
Okay. So what investigations will you do for this case? Now the main point is to differentiate between primary and secondary atrophic rhinitis and ensure fitness for any procedure or treatment. So these are the two goals of investigation. And any investigation should be specific to the diagnosis. Initially specific investigations only.
Yes, sir.
Okay. So she has asked for test for tuberculosis, basically when it comes to the first point and also the chest X-ray. Lepramine test, I don't know if it is done. So nowadays leprosy is diagnosed not by lepramine test, which is basically you're injecting the antigens into the subcutaneous part and looking for a reaction, as far as I remember. But what we do is nowadays we take a biopsy of the septal mucosa, and then that is examined for acid-fast bacilli. That is how leprosy is typically diagnosed now, apart from the clinical features. So the main investigation, the to differentiate between primary and secondary atrophic rhinitis will be biopsy of the nasal mucosa, usually from the inferior turbinate or from the anterior part of septum. Okay, apart from this, there are some endocrine causes, right, for atrophic rhinitis. So, do you want to do any endocrine investigations?
Blood investigation is done.
What investigations?
Like you said, hypothyroid might be related, so we
Yeah.
can do thyroid function test.
Yes.
T3, T4.
What other endocrine diseases you can expect or think about?
Diabetes, sir.
Pardon?
Diabetes, we check for the blood sugar.
Diabetes. Anything else? Hypoestrogenism in women that can predispose to secondary atrophic rhinitis. So we will do gonadotrophic hormone estimation like estrogen, progesterone, and testosterone in a patient who is having atrophic rhinitis, if you are suspecting such a cause.
Okay, sir.
X-ray PNS, like I mentioned in the last class, it has very limited utility. I will not be giving much importance to it. Maybe a very old styled examiner will accept it. So CT scan would be useful, but in this current case, it may not be of much use. Maybe to plan for the surgery, you can consider doing a CT scan.
Yes, sir.
One more thing which you can consider is a routine hemogram, because anemia can be iron deficiency can be one of the cause of atrophic rhinitis. Okay.
Yes, sir.
Okay. Does anybody have any questions, doubts, something to contribute for till now, till investigations?
And in blood test, we can do absolute eosinophil count, IgE levels, everything to rule out allergic rhinitis if we do, right, sir?
That is for allergy, no? Not in this case.
Okay, sir.
There is no role for allergy in atrophic rhinitis. Okay, so we quickly go through the slides, remaining slides, what you have. We have only a few minutes.
So 2 more slides. It's only about the treatment.
Yeah,
And
just show it. Go to the next slide. Okay, so I think this has been discussed in the last class, no? I think usually it is discussed.
it was discussed.
All of these were discussed?
Yes, sir.
Yes, sir.
Any surgical videos were shown to you in the previous class?
It was shown, sir.
Pardon?
Yes, sir. Sir projected a surgical video.
Of which surgery?
Modified young.
All right. So we have completed the class today. Case discussion of a patient with atrophic rhinitis. You have any doubts, or you want me to repeat any particular part of this disease or case presentation? Anyone can answer.
Sir, could you explain that modified Young's procedure once again?
Okay, which video was shown to you? Was it the one by Dr. Vikas Sinha? Okay, so are you seeing my screen?
I'm giving the incision. Now, similar
Yes, sir.
incision being given at
Just give
the
me a second.
septal side. Incision is extend.
So I found one video of modified youngs. Unfortunately, my own surgery I have not recorded, but let me try to share the YouTube video, and then I can explain it as it goes along. It's only around 4 minutes. So okay, are you seeing my screen now?
Yes, sir.
Yes, sir.
So this is Dr. Vikas Sinha's video. You can search on YouTube. It's easily available. I'll just play it.
Extended towards 12 o'clock position. There should be a complete circular incision.
So basically
Now, with
what
the
he is
help of
doing,
sharp curved scissor, I'm creating a flap. Now, this is the up.
so he has taken a circular incision in the nasal vestibule, at the nasal valve area, involving only the skin and septal skin and vestibular skin. The incision is a circular incision. That means it goes all around the vestibule, above to below. Right. Afterwards, he's using a sharp curved scissor, and he has inserted the scissor through the incision and is elevating the skin from the underlying cartilage and soft tissue. You can see the tip of the scissor below the skin.
Upper flap is being created. The flap should not have any tear. So the caution is required. The flap is being created. Similarly, the upper flap is being created towards the septal side. And I'm creating the flap at 12 o'clock position. Similarly, flap is being created at the 6 o'clock. Now I'm creating the lower flap at the septal side.
So one more flap is elevated posteriorly. It involves the septal mucosa and posterior nasal skin.
Now I'm suturing these two lower flaps.
And the elevated flaps are closed in two layers. One layer is inside and one layer is outside.
There is a lower flap and the upper flap, and this lower flap is being sutured. One should ensure that the flap should not have any tear while suturing it. Now I am passing a small polythene tube, which is about say 2 millimeter of the width. The purpose of this tube is that a 2 millimeter hole is being left out. Now the upper flap is being sutured.
So this is a type of modified Young's, not a true Young's operation. Okay.
You should use the absorbable suture material. Now I'm ensuring that the flap is completely sutured. Now the small.
So that's all. That is the end of the procedure. I just put the link for you all. Give me a second. Did you understand this procedure?
Yes, sir.
Yeah. So basically taking a circular incision in the nasal vestibule, elevating flaps both anteriorly and posteriorly, and then bringing up both flaps, suturing them in the midline. So one problem with this is if you don't elevate properly, it leads to a depression of the nasal vestibule. So aesthetic appearance will not be good. Any other questions? put up the link for the video Rajiv S R. So